Okay, well, we're going to get started on our weekly bar shop, shock center, pepper center, crack seminar series. So thank you very much for coming. And it's a pleasure to introduce Dr. Shireman, who I've worked very closely with her in the last few years in her roles in the leadership in the School of Medicine. And I need to acknowledge that she has been extremely supportive of our institute and our aging program. So I want to acknowledge that publicly, as well as she helped with our center grant application. So I want to start with that, and then moving on, talking about her background. Well, Dr. Shireman, I didn't know that she had a bachelor's in nutrition science, so we share some interest in metabolism. Maybe you should be a member of our Diabetes Research Center grant that we're writing. Why not?
We'll talk later.
Well, Dr. Shireman then obtained her MD at Indiana University, her medical degree, and then internship residency in general surgery, who, for those who don't know, lasts 7 years. In those days, I think calls were every other night, probably.
There was a lot of them.
So things have changed since then, but I just acknowledge that because I did 1 month of rotation in surgery and I barely survived it. So. Then she specialized in vascular surgery and then subspecialized in peripheral vascular surgery, and she's board certified in general surgery and vascular surgery. In addition to her clinical training, she has been a very successful scientist and has done work in several areas related to vascular biology, muscle biology, and regeneration, the role of the immune system, particularly the monocyte and macrophage, on muscle regeneration, and also adipocyte regeneration related to vascular problems and trauma. And she's also has an interest in other broader type of sciences, including outcomes, implementation science, and translational research, in addition to her basic science program, which has been funded by several agencies, including NIH and the VA. She also has been the co-PI of our CTSA and PCORI grants from the university. Currently, she, in addition to being a professor of surgery and microbiology and immunology, she also has, she is Vice Dean for Team Science at the School of Medicine and Dielman Chair. She has many publications, and many of them are related to aging, and I think she has an interest in aging as well, and I think that's what she's going to tell us about today. Thank you, Dr. Shireman.
Thanks, Nick. All right. Probably need this one. All right. There we go. Well, it's a pleasure to be here in front of a friendly audience. You are going to be a friendly audience, right? Okay. And as you know, I know no holds barred in the bar shop. If you have questions or go ahead, feel free to interrupt. So I've spent a lot of time studying skeletal muscle regeneration. And why should we study muscle regeneration? Well, as a vascular surgeon, oftentimes I'm called in for trauma or even for arterial disease or embolic disease or something, and we will revascularize the leg only to find that the muscle is dead. And so we have to do an amputation anyway. So muscle, if you think about it from an extremity perspective, is the tissue that is most sensitive to ischemia. And then the other interesting thing about muscle is that it regenerates throughout the lifetime of the individual. I mean, if you think about that, right? Cardiac muscle sits in your chest and it's in a protected environment, and when it, and you can pass on your genetic material to your offspring, and when you have your heart attack, hopefully they're already old enough to survive. You couldn't run away from the saber-toothed tiger if you didn't have good muscle, and you couldn't regenerate your muscle with injury. So it's really essential to our survival that we actually regenerate and that our muscle regenerates throughout our lifetime. And there's this easily accessible progenitor population within muscle. They're called satellite cells or myogenic progenitor cells. So technically I could take a muscle biopsy from any of you and grow your own myogenic progenitor cells and use them for something that would help you. And obviously with fetal stem cell and IPS and all of the other things, there's always issues with that, but no one is against taking your own cells to help you. And since muscle is so easy to obtain, you can do that. And young patients need self-coverage too. I mean, there's a lot of degloving injuries, and so as Nick had alluded, I also have the Health Services Research Grant that looks at the long-term outcomes of vascular trauma for Iraq and Afghanistan veterans. And improvised explosive devices, or IEDs, are really the main source of injury now for our service members. And with those come huge degloving injuries where soft tissue is gone. And if you could regenerate muscle, then you could salvage a lot more limbs and make them functional. So when I think of muscle regeneration, I think of multiple processes that come together to make this happen. So one is angiogenesis, which is basically capillary formation. As a vascular surgeon, I think a lot about blood vessels and the vasculature. And if you don't have perfusion, you have dead tissue, wherever that is. And the satellite cells, which are that myogenic progenitor cell population we talked about earlier, we have been particularly interested in bone marrow-derived cells. So some stem and progenitor cells can actually travel from the bone marrow and enter injured tissue, including muscle. From our perspective, we really look at the inflammatory cell population and predominantly macrophages. We've spent a lot of time looking at the MCP-1 and CCR2 axis. So MCP-1 is monocyte chemotactic protein 1. It's a pro-inflammatory chemokine. It attracts and activates monocytes. And its receptor is CCR2, the CC chemokine receptor 2. Now, in the chemokine system, one receptor combined multiple chemokines. So they're permissive is the term that's used. So unlike what you're used to for the most part where you have a receptor and a ligand, the chemokine system has a permissive environment. And in mice, CCR2 binds MCP-1, MCP-3, and MCP-5. So there's more than one chemokine that can actually bind to the CCR2 receptor. So I always like to start out with this is what normal skeletal muscle is, and this is a cross-section through the tibialis anterior, and so you can see that all the fibers are in cross-section here, and the lovely thing about skeletal muscle is that when it's injured, you can tell this because a quiescent or normal muscle has peripherally located nuclei. So if I injure muscle, the nuclei become centrally located and then over time migrate to the periphery. So it's a really nice indicator for injury and resolution of that injury to look at where the nuclei are. And so to just give you a sense of what happens in young mice, and I promise I'll get to old mice because this is the bar shop, and we have actually quite a bit of data now on our mice, but I want to give you a sense of what these are young male mice, what skeletal muscle injury does. And so we use cardiotoxin, which is a snake venom, and essentially what it does is it activates complement and causes massive necrosis. So you saw the nice orderly skeletal muscle that I showed you before. At day 1, and this is in the wild type mouse, you see a total disruption of the tissue architecture. There's edema, that's what these white spaces are. This kind of pale pink are dead skeletal muscle, and then you see a lot of these purple, which are nuclei, and in day 1, it's predominantly a neutrophilic infiltrate. So just like a innate immunity, essentially you get neutrophils coming in first. And in the MCP-1 and the CCR2 knockout mice, it really doesn't look very much different. So you really can't tell them apart at day 1. By day 3, however, you start to see very big differences between our wild-type mice and our knockout mice. So the wild-type mice, there's this intense monophilic infiltrate, monocytic infiltrate, and most of these nuclei belong to macrophages. Some of them are myogenic progenitor cells, but the vast majority of these nuclei are actually macrophages that come in to basically phagocytize the dead muscle and to create muscle regeneration. In MCP-1 knockout mice, you see some infiltrate, but you also see a lot more dead tissue and not nearly this robust macrophage infiltration that we see in our wild type. And in CCR2 knockout mice, there's hardly any macrophages at all that come to the party. And we've used a lot of work with flow cytometry by taking the muscle and making a single cell suspension and basically quantifying that infiltrate. So I can show you pictures and say, believe me, there are very few macrophages there, but we like to be quantitative in science. And so this is CD45 positive, CD11B positive, Ly6G negative cells. So these are macrophages and monocytes. And at baseline, you can see that there's very few macrophages in the tissue, and that's what you'd expect. In a wild-type mouse, shown in blue, you can see that the macrophages increase. They peak at day 3 before starting to come back down to normal. And then by day 14, they're basically similar to baseline levels. In MCP-1 knockout mice, you get some macrophages here in yellow, and they come in, and by day 7, they look pretty much similar across the 3 mouse strains, but you don't see that huge increase that the wild type had. And the CCR2 knockout mice have hardly any macrophages that come in. Now, this is, timing is everything. There are some publications that look at CCR2 knockout mice and say there's no difference in macrophage recruitment between that and wild type, but they're looking at a day 7 time point. And I would agree, at day 7, it's pretty similar, but you never get this huge macrophage infiltrate that happens in our wild-type mice. So timing is everything, and one time point is one time point. So what does the muscle look like at day 7? So a wild-type mouse has really small but regenerated myofibers. And remember, we talked about the location of the nucleus. You can see that these are all centrally located nuclei. There might be, in fact, I'm not even sure I can see a single muscle fiber here that doesn't have a centrally located nuclei. In an MCP-1 knockout mouse, you see that there's still a fair amount of necrotic tissue. That's what this pink thing is. You have really small myofibers. And still some inflammation. And in the CCR2 knockout mouse, there's all of this dead muscle tissue, hardly any regenerated myofibers, and you can kind of see this cell that's wrapped around this dead piece of tissue. That actually is a myoblast that's trying to regenerate and grow, and what I like to think of as a sea of garbage, right? Because it never was able to clean up all the dead tissue. At day 14, nothing much happens with the wild-type mice other than that the fibers continue to grow in size. So they're smaller, they get bigger. The MCP-1 knockout mice by this time have no residual necrosis, but they have some pretty small fiber size. And here in the CCR2 knockout mouse, what you see are these adipocytes and still some necrotic muscle right here. So even at day 14 after injury, the CCR2 knockout mouse still has necrotic tissue. So we're also able to use histomorphometry to look. Yes.
Yes. Does the timeline change depending on the amount of damage in the muscle? Like, will it take longer or shorter if it's more mild?
We used multiple different types of injury. We've done ischemic injury where we've excised the femoral artery. We've done cardiotoxin and then done cardiotoxin again, so hit it a couple of times. I think that kind of the series of events is similar, and there have been some papers where people have looked at barium chloride, notoxin, which is a little bit different than cardiotoxin, freeze injury, and all of these things. I think you can get your timeline to change a little. Like if I made my injury much worse, maybe the MCP-1 knockout at 14 days would still have necrotic tissue, but the series of events pretty much is the same. And, you know, in the CCR2 knockout mice, as I'll show you, they get a lot of adipocytes. And people who have published, we've seen this with the ischemic injury model in our lab. We've seen this with the cardiotoxin model. And another lab that uses freeze injury also showed it. So I think you can injure something in multiple ways, but there's only so many ways the body can react to an injury. And so I think, like I said, I could probably make this a little different if I put more cardiotoxin or less cardiotoxin, but I think the sequence of events is pretty solid and pretty fixed. So here in our mice, these are baseline myofiber sizes, and you can see in our wild type MCP-1 and CCR2 knockout mice that, you know, the average cross-sectional area of a baseline myofiber, you know, peripherally located nuclei, is somewhere around 2,600 micrometers on average. At day 7, remember I showed you the images of the day 7 mouse, the wild type mouse is pretty much regenerated, but the fiber size is small, and this asterisk just essentially basically points out that it's smaller than baseline. By day 14, you can see it still increases in size. By day 21, it's still smaller than baseline, but by day 28, it's a similar size, and it's reached its baseline size. However, the nuclei are still centrally located even at day 28. It takes a much longer time for the nuclei to go to the periphery. And remember, we talked about the MCP-1 having an intermediate macrophage recruitment. Well, you can see in yellow that if you look at every time point, you see that the wild type fiber size is largest, followed by MCP-1, and then CCR2s are even much smaller. So the fiber size is least going in association with the macrophage recruitment.
So these are the comparison of the fiber size, right?
I'm sorry, the fiber
size, right?
This is the, we basically draw circles around the fibers and we get an average fiber size. And so these are all from centrally located nuclei, the regenerated ones. The baseline are from the peripheral.
But if you compare the number of the fibers, is there any difference among those three groups?
Well, it's hard to say. In other words, to really compare the number of fibers, you'd have to look at, say, a whole tibialis anterior muscle. Because if I take a picture and there's edema in that picture, then there's a lot of space filling from that. And to try to get a really good injury across the whole tibialis anterior, when we do this, we don't accept images that have a lot of peripherally located nuclei. In other words, we're trying to get areas that are damaged, and we know which ones they are because we can tell based upon the location of the nucleus. So we've really not tried to count the fibers. You know, we have actually, when we've done capillary density, you know, you can do caps per area or caps per fiber. We tend to do caps per area only because the CCR2 knockout mice have such small fibers that if you do caps per fiber, well, you've got the fibers that are different, and so I don't know how to interpret the capillary data. Yeah?
So do they stop using their injured leg and then kind of between that, the 7 and 14 start again, so that helps to build the fiber?
I would say that we've done single injections on one leg, and we've done bilateral injections. What generally happens is at day 1, their leg is swollen, and they tend not to use it if it's a unilateral injection. By about day 2 or 3, they're walking pretty normally, and you know, by day 4 or 5, you really couldn't tell just from looking at a mouse whether it had been injected or not. I suspect that they do probably favor the leg if it's a unilateral injection. And in the early days, we thought, well, each mouse will serve as its own control. You know, let's just double the work, right? Grad students love that kind of thing. What we found is that we usually injected the right leg. The left leg over time changed a little. I mean, the fiber size, and so chances are there are some subtle differences. So we, you know, in other aspects. So we've just basically said, now we're not going to try to play the game of each mouse as its own control, because I really don't know what the effect of that, you know, the normal leg and the abnormal leg is doing. So we just have gone to baseline. It did. Mm-hmm.
I think she's asking the question whether or not exercise actually affects this regrowth curve.
Yeah, and I don't have any.
No, in fact,
Right. I mean, they use the leg. And they may not use it as well as an uninjured leg, but I have not tried to put them on a treadmill. At one point in time, we wanted to try to measure their those rotorods, which really are more about balance, but what we thought is we could try to use a rotorod as a means of trying to assess return of function to the leg. And this is where mice were smarter than us, and they were running on 3 legs. So, you know, we would have had to do bilateral. So we tried a lot of different things to try to get at that point, but I think the mice have always outsmarted us. So muscle regeneration, I hope, this doesn't prove it, of course, but I hope that you're starting to think that maybe muscle regeneration, that macrophages play an important role. And by ablating or decreasing macrophages, there's impaired muscle regeneration. And MCP-1 and CCR2 knockout mice have impaired macrophage recruitment, and at least we can't prove that it's due to the macrophage recruitment, but at least it is in association with impaired macrophage recruitment. So and the other problem, of course, is with the CCR2s, they never get macrophages in. So we then started thinking, well, what if we could really just time when we got rid of the macrophages and then let them come back? You know, does it matter the timing of the macrophage infiltrate? So we hypothesized that ablating macrophages at early and late time points would have different impact on skeletal muscle injury and repair. So for this, we used a CD11B FEB DTR mouse. And so this mouse is on an FEB background, and mice do not have diphtheria toxin receptors. So you can give them all the diphtheria toxin in the world and they don't care. However, these mice have diphtheria toxin receptor on a CD11B promoter, and CD11B is on macrophages, monocytes, and neutrophils. It's more highly expressed on monocytes and macrophages than neutrophils, so that when you give a dose of human diphtheria toxin, the macrophages primarily are ablated for about 2 days, and then they come back. And so we had a control group of mice that were the same mouse, but we had a mutant diphtheria toxin that would not bind to the receptor. So we wanted to have a control that, if there was any type of immunogenic reaction to the diphtheria toxin itself, that, this would be a good control. So first of all, we wanted to make sure that we actually were ablating cells. So everything here, when we talk about the diphtheria toxin, it's in regards to when we did the cardiotoxin injection. So this is muscle that has been harvested 2 days after a cardiotoxin injection, and we gave the diphtheria toxin 1 day after cardiotoxin. And you can see that there's still this robust mononuclear cell infiltrate in some necrotic muscle. However, if we give the diphtheria toxin, the active live diphtheria toxin, you can see that there are very few macrophages, or at least mononuclear cells here, and a lot more necrosis. So what we wanted to do then was try to figure out when would be some good time points for us to give the diphtheria toxin. So we have our controls, and then we gave diphtheria toxin at basically 12 hours prior to cardiotoxin injection, at the same time as cardiotoxin, at day 1 after cardiotoxin injection, day 2, and day 4. And we sacrificed the mice at histology day 7 because we can do residual necrosis, cross-sectional area, and fat accumulation. So it's a nice time point to get a lot of different things. And when we did this with our CD11B ablation, what you can see is here's residual necrosis, and here is our control down here in the blue. And in the FEB mice, they tend to have a bit more necrosis, residual necrosis at day 7 than our C57BL6 mice do, but still it's about 4% of the area is necrotic. However, if you give the diphtheria toxin 12 hours before cardiotoxin, the residual necrosis goes up to about 20%. If you give it at the same time, then that's the pink one here, it goes up higher. At day 1 after cardiotoxin injection and day 2, it's pretty similar. If we give it at day 4, then we really don't have an impact at day 7 on necrosis, on residual necrosis. And we can kind of see the same thing for cross-sectional area. Here's the control. It has small myofibers because a FEB baseline mouse has about a 2,500 cross-sectional area. So they're small, but they're there. And depending upon when you give the diphtheria toxin, we see a nadir. Basically, if you give the diphtheria toxin 1 day after cardiotoxin injury, which basically ablates the macrophages at day 2 and 3, this is where our cross-sectional area is the smallest. And interestingly, for fat, if you give the diphtheria toxin essentially at the same time as the cardiotoxin, we get increases in fat. So we did a lot of work essentially with the day 1 time point with the diphtheria toxin. And if you want to look at that, it's in the American Journal of Pathology. Hanjo Wang, who was a postdoc in my lab at the time, did the vast majority of work on this. And just to kind of summarize, we did a lot of work with the macrophages and what macrophages were there and what's not. And to cut to the chase, just because I know you want to get to the aging data, is that early macrophage ablation altered the accumulation and magnitude of Ly6C positive, which are the pro-inflammatory macrophages, and the Ly6C subsets, and that maximal Ly6C is positive, which is the pro-inflammatory, is delayed, but it actually reaches the same level later on. However, what we didn't see was the Ly6C or the anti-inflammatory macrophage accumulate, and so basically we were missing that Ly6C negative. And I don't name these things. I mean, it doesn't make sense to me that we have an anti-inflammatory macrophage, but that's what they call it. So this kind of gives you a backdrop into the, yeah.
Okay. So the model of ablating macrophages with MCP-1 knockout, by knocking out,
Right.
Would it be possible that there's also an effect on, due to the local expression of MCP-1 in muscle?
Yeah. Well, MCP-1 does a lot of things. I presented it before here. It's in the FASEB journal. Because you have a much more severe phenotype in the CCR2 knockout mice, we did a chimera experiment where we irradiated wild-type and CCR2 knockout mice and gave them either a wild-type bone marrow or a CCR2 knockout bone marrow, and the bone marrow was from GFP mice, so we could track the cells. And the take-home message on that, because we were, CCR2 also, it's on endothelial cells, myogenic progenitor cells, it's on a lot of different things. And what we were able to show with that is that the phenotype of muscle regeneration and macrophage recruitment was not dependent upon the host mouse, but was dependent upon the bone marrow we gave it. So in essence, we could take a wild-type mouse and make it look like a CCR2 with impaired muscle regeneration if we gave it a CCR2 knockout bone marrow. And alternatively, we could rescue a CCR2 knockout mouse by giving it a wild-type bone marrow. And then we've got a paper that's submitted, I'll show you some data from it, but I didn't include this data in that where we isolated myogenic progenitor cells from wild-type mice and CCR2 knockout mice, and we grew them in culture, and we looked at proliferation and differentiation. And under culture conditions where they're being treated the same, the myogenic progenitor cell from a CCR2 knockout mouse does just fine. So I think it's the bone marrow. Of course, with the CCR2 experiment, all we can say it's a bone marrow cell. We can't say it's a macrophage. But those were the cells that were pretty much missing. So sarcopenia, yeah, now I'm getting everyone's attention. We got it.
Before you move on, can I ask you just my question?
Yeah.
What do those macrophages do? I mean, you said that just to clean up the cells. Right? That's one thing. And another thing I'm wondering is if those macrophages could produce some kind of growth factors for angiogenesis or the growth factor for the regeneration.
Oh, they do a lot more than just clean up they're more than just garbage collectors. They are cytokine factories. A lot of people believe for angiogenesis, endothelial cells can burrow through the extracellular matrix and make a capillary, but what you find is that the macrophage is much better at it, and so capillary formation will follow a macrophage. And then when we look at our tibialis anterior muscle, what we find is that regeneration happens from the outside in. So basically the capillaries come in and then the muscle regenerates. So macrophages are important in angiogenesis, in making cytokines, and there's a fair amount of literature of myogenic progenitor cells and macrophages cross-talking. And if you look at the architecture of normal skeletal muscle, the myogenic progenitor cell usually sits right by a capillary, which, you know, so if there's a problem, a macrophage or a neutrophil or something will come out of that capillary or the post-capillary venule. And so there's kind of that triad. Early warning system.
I'm trying to consider humans. So if you have an injured human, let's pretend they're young before we get to sarcopenia, or the middle age injured. Are the number of macrophages limiting, or do they get there too late, or are there not enough on the third or fourth day? Do you know?
You talking about in humans?
Yeah.
Well, it's a mixed bag. I mean, it depends on who's looking, where they biopsy, what they did, and everything else. And not all macrophages are created equal. So some are pro-inflammatory, some are anti-inflammatory. And I think a lot of, there's a lot of nature papers about this wonderful cell type, and it's got like 15 markers, and a lot of times I think they're really just looking at macrophages. I think they are the great masquerader. They can do a lot of different things. So in humans, I mean, it's variable, but certainly if I took a trauma patient who had some injury, the sequence of regeneration, you wouldn't be able to tell it probably from a mouse versus a human. I mean, it's going to go through that same, and it depends upon the degree of injury.
Well, and that's what I thought, because you might be able to improve making it a nice environment for angiogenesis if you could have more and longer macrophage in the people. You might get a better outcome.
Right, or you might not, right? So I think, timing is critical, and I mean, that's, we ablated the macrophages in those FEBDTR mice at day 4. And, I didn't show you some of the later time points, but the fiber size was similar to the control, adipocyte accumulation. So why is it that if you ablate macrophages at day 2 and 3, and then they come back, even though they don't come back quite the same as the normal progression, why do you have impaired muscle regeneration out at day 14? I mean, the fiber size at day 21, I think we went to, was still smaller. And maybe it would have caught up over time. But there is something about the timing and the sequence of the macrophages that come in and how they differentiate and polarize that's critical. And we think in chronic inflammation, something happens that arrests it, that doesn't happen through that normal cycle, and that's where chronic inflammation comes.
So, back to the basic molecule of the acute injury. What do the T cells do in this?
We've done some work with T cells, and we don't find many T cells in this. When we have done, way back in the day, we used to use nude mice, which are without T cells, although there's some leakiness to that, where some of them have some T cells. Muscle regeneration was perfectly fine. And There are some papers, though, that say T cells are critical. I don't know that I believe that too much. Back in the day, there was a guy by the name of Jeff Isner who did all the VEGF work. And he would do hind limb ligation and legs would fall off. I can't tell you the number of mice that I did, because, you know, a leg falling off is a pretty convincing phenotype. You know, you can't fake that. You know, I might try to convince you that a small change in cross-sectional area is significant, and you may believe that or you may not, but a leg falling off is a leg falling off. I can tell you out of the probably 1,000 mice that I've done hind limb excisions on, we've had 2 that have lost their hind limb. And we did the nude mice. We did the nude mice on the same background from the same vendor that he bought them from. We did all this stuff. So I don't know. He was a cardiologist. I'm a surgeon. Maybe we didn't spit in the wound or something. But we could never replicate the data that Isner had with T cells being so critical. I mean, legs just didn't fall off. So, yeah, so to sarcopenia. So the definition is loss of muscle mass with aging. I guess I didn't need to tell this group that. But what are the causes of sarcopenia? And I think this is still kind of controversial, although, you know, there's obviously several camps. So one theory is that it's really just impaired regeneration, that you have a satellite cell defect as the human or the mouse or whatever ages, and it just can't overcome the normal wear and tear that satellite cells get tired and they poop out. Another one is that maybe there's impairments in satellite cell numbers with aging. So myogenic progenitor cells really can only make muscle, but some of them go to muscle and some of them you know, become myogenic progenitor cells. So they self-renew. So maybe you just have fewer satellite cells with aging, and that's why we get sarcopenia. And then there's also this theory that it's the aging environment, that the satellite cells are just fine, but they're surrounded by an aging environment, like, you know, like the CCR2 knockout mouse. Their satellite cells, I think, are just fine. They don't care that they don't have CCR2, but they didn't have the macrophage around to help them do what they needed to do. So there's a lot of talk, and there has been, about whether you could give stem cell therapy for sarcopenia. Can and then of course there's the controversy of, well, if I take the stem cells from the elderly person and give them back, they might be defective, so can we take them from somebody else and give them to it, and all of that. So there's a lot of literature around that. And so the pro of, you know, we had Irina Conboy here, and she talked a lot about her parabiosis and her cell cultures, and she has a lot of really high-profile articles in Science and Nature talking about how defective old stem cells are. And, you know, you can kind of see there's a huge literature on a lot of really high-profile journals saying that stem cells, that myogenic progenitor cells, are defective as we age. Most of these studies, though, have really relied on extensive cell culture and have not been within the mouse itself or the human or wherever you're looking. On the other side, that aging satellite cells can regenerate muscle, and that's not the cause of sarcopenia, is Miranda Grounds, who's been in muscle biology for a very long time. She's in Australia. She wrote a really beautiful review about this, going all the way back to some of the Carlson and Faulkner EDL models. And she really referenced this Lee paper, where they basically took young and old and senescent, 28 months. So I think that's pretty fair. And these were female mice, C57BL6J. And they basically injured them in 3 different ways, which gets back to that question of, you know, do different injury models matter? And they did muscle function and all of that. And they basically said, these senescent mice, which are 28 months old, they get the same power from their regenerated muscle, and they regenerate just fine. And then, of course, the Fry paper from Nature Medicine, Charlotte Peterson and Esther DuPont-Verstegen. And, you know, we've talked to Charlotte and to Esther. They had a hard time getting this published because of all the other Nature and Science papers and the people who didn't want satellite cells to not be the cause of sarcopenia. In the Fry paper, what they did is they pretty convincingly ablated satellite cells. There was maybe 10% of the satellite cells. And then they let the mice age. And when they did that, there was no sarcopenia in the mice, despite ablating their satellite cells at a very early age. Now, when they gave them an injury, they didn't regenerate very well, but they didn't get sarcopenic. And like I said, if you ever get the chance to talk to Charlotte and Esther about this, they really had a hard time getting this paper in a high-profile journal because no one wanted to believe this. And I will say, hopefully some of the data I will show you, I'm in the con camp. Our data is very similar in that aging mice actually regenerate very, very well. But getting to sarcopenia, so we looked at C57 BL6J mice, and we were kind of interested in some other things, but we did get their body weight. And so I know it's politically incorrect now to do blue for boys and pink for girls, but you know, I'm a girl, so I'm going to do blue and pink so we don't have to try to remember who the boys are and who the girls. The last time I saw a presentation, they used blue for females, and it just rocked my world. So if you're not going to do blue and pink, don't use blue or don't use pink. Use two different colors. So our young mice were 4 to 6 months of age. I know you have to tell everybody at the bar shop what your age groups are, right? Our middle were 12 to 15 months, and our old were 25 to 30 months. So I've been well schooled by the bar shop about old being old, you know, and old is not 12 months, got it. And then we just happened to have a group of males that we called very old, and they were 32 to 33 months, but we don't have the females to go along with that. So we did their body weight, and it's interesting, at least the pattern with the males, in that really they didn't have any significant change in body weight over time. And we've always used young to be 4 to 6 months because a lot of people use 8 weeks. So now I'm going to discriminate on the other end. You know, mice grow very rapidly from 8 weeks to 12 weeks, and on average 12 weeks is kind of when they plateau out. So we usually wait till another 4 weeks after that, so 16 weeks, so that we aren't catching mice on that, you know, so the laggards aren't still growing. And we do know that our cross-sectional area from about 16 weeks to about 30 weeks is really similar. You can't tell the difference in cross-sectional area on a baseline mouse. So we've never used, you know, the really young mice because I think you get a lot of artifact, if you will, with growing and the size. So in our young mice, the males really did not have a significant change in weight, but the females increased in size compared to the middle age and then decreased. And the pound sign here just means that it's significantly different than the males. So it's no big surprise that female mice weigh less than male mice. So we also did the anterior compartment weight. Now I know if we were really good, we would have just done tibialis and done the muscles individually, but we took the whole anterior compartment and weighed it. And essentially, you've got the same thing with the males. The anterior compartment weight doesn't change over time, except by the time they got to be very old.
Can you describe what anterior compartment is?
Sorry, I'm a surgeon. So, if you look at this area here, it's the same in mice. The anterior compartment and the posterior compartment, you know, you talk about your sore gastrocnemius muscle or your gastrocs, that's in the posterior compartment. So the anterior compartment has the tibialis anterior, the extensor digitorum longus, and 3 other muscles that I never remember their name on. But that is the compartment. And the reason we've kind of stuck with the tibialis anterior is when we do a cardiotoxin injection, you have to be good at it. And I have a tech who's really good at it. He can routinely get 60 to 90% injury in the tibialis anterior muscle. When we do injections in the posterior compartment, it's a lot more patchy. So you might get a really good injection will give you 40% injury, and another one might give you 20. So when we do our histomorphometry, the first pass is that there has to be at least 50% injury or more, or we don't do that. And I have a lot of people that I've trained on this model that when they practice or when they do it, they don't get a very good injury. So we only, you have to be able to prove that you can reproducibly give good injury on this model.
Does the weight change occur in the dams, whether or not they were allowed to be pregnant or not?
We've done both. So this is a mixture of female mice that have never bred and female mice that have. And when we've looked at the ones that did, were being used for breeders versus the ones that never were, we really didn't notice any difference. But I wouldn't say that I have hard and fast data on that. So what happens to myofiber cross-sectional area? All right, so once again, you've got the males, and it's about 2,500 in a young. It maybe goes up a little, but there's really no significant difference. But by the time they get to be old, 25 to 30 months, they're significantly smaller than the young in the middle. And remember, the weight and the anterior compartment weight didn't change in that time frame. And essentially, the very old have a similar baseline cross-sectional area as our old. So in the male mice, their weight didn't really change, their anterior compartment weight didn't change, but their fiber size did go down. And that was, as far as I'm concerned, the first indicator of sarcopenia. In the females, the fiber size, once again, is smaller than the males, not too surprising. But the young and the middle-aged females have similar fiber size, but they are significantly larger than the old females.
The fiber size is the less in the old, the male. Still the weight is the same. So what make up the rest of the part?
When you look at, you can always tell old muscle and even middle-aged because they have these kind of inclusion bodies in them. So but generally it doesn't look all that different. So there might be a little bit more fibrosis, but even then it's not fibrosis. I suppose if you did a trichrome stain, there might be more connective tissue. But it doesn't really look very different. And in fact, if I showed you, because I know how good of a pathologist you are, middle-aged baseline muscle and old-age baseline muscle just on an H&E stain, I don't think you would be able to tell it apart. Because, the cross-sectional area is really hard. You can't look at that and see it. So what about with regeneration? So I chose green for the young because, they're young and green. Sorry, students. The gray is because old people are gray. And the middle age, well, I got nothing. I don't know why I picked red. It just was a nice color. So anyway, with males, if we look, and so this is where, you can kind of see the ages together. You see the young, the middle, and the old at baseline. And so you have a smaller fiber size. But when you look then at regeneration, okay, so we had a lot of mice in these groups. There's a significant difference here compared to the young, but really there isn't a lot of difference in regeneration. I would say that's probably not physiologically a significant difference. And the young and the middle really just regenerate on the same kind of trajectory, and the old keep up with them until they get to a point where they're trying to hit their own baseline fiber size. So they don't get bigger. There's something, and this is something I've talked a lot about with my lab, and I don't even know how to study it. There's a set point that muscle's only going to get a certain size, and I don't understand why that is, but this old muscle will not get bigger. Don't know why. And it doesn't have the inclusion bodies in it when it's regenerated. I suppose over time it probably would get it, but a regenerated fibers, they don't have the inclusion bodies.
What do you mean by inclusion bodies?
I think we've looked up what they supposedly are, but there's just these little, like I said, I can always tell middle and old age baseline muscle from young because I don't have a picture of it, but I can show it to you, in a lot of different pictures, but I think it's, glycation products or something. I don't really know what's in them. I just know that they're there. It's in the cytoplasm, yeah.
resting or something?
I don't know.
Energy?
I don't know. I didn't do that.
Yeah. So males, old males regenerate pretty well. They get back to baseline essentially at about the same time a young or a middle-aged mouse will get back to baseline. Their baseline is just lower. So what about females? Well, females have some issues with regeneration. I don't know how physiologically significant it is, but certainly the middle and the old age females are smaller at day 7 than the wild type, and then the old age are still smaller, and you can kind of see this trajectory. And basically what happens with the middle age, at even day 28, they're not back to baseline, and there's a significant difference between the day 28 middle-aged and the baseline. However, the females, the young are actually overshoot baseline a little, and the old age females are at baseline by day 28.
Do you know what happens with subsequent injuries? So if you let them recover all the way and then injure again, is there a diluted effect?
We've done a little bit of work on that. You're gonna have to get that by IACUC. They don't like you injecting cardiotoxin on repeated cycles with one mouse, and we can understand that. And we haven't done a lot of work with it. We did it mostly in young mice. And you know, the CCR2 knockout mice don't regenerate well, but the wild types, when we did it, they seem to regenerate pretty well if we kind of let them recover and then inject them again. But I don't have a lot of extensive data on it.
So is there evidence from people that multiple injuries, that you're not able to, that maybe multiple injuries could lead to sarcopenia faster?
Well, I don't know that there's data out there. Is it possible? I suppose. We certainly know the severity of the injury makes, if you go to the gym and you work out and your muscles are sore, you've regenerated muscle, and that's how you get bigger muscles. You rip them down and you tear them down and you build them back up. But whether, certainly you can injure something past the point of no return, right? With the ischemia, you can get muscle volume loss, and a lot of Iraq and Afghanistan soldiers that have been injured by IEDs, they kind of have scarred skeletal muscle, and they never get back to the big volume of muscle that you would normally have. So you can get to a point of no return, I think, with muscle injury where it pretty much scars. And I also think it depends upon probably genetics. I know with the inbred mouse strains, the C57s, I really don't get scar tissue in them. When we really push the injury level on them, we get fat. On bulb Cs, however, if you injure them, you can get kind of scar tissue and fat. So I suspect, depending upon, and DBAs, they heal worst of all. I mean, they really will look bad with a similar injury to a C57. So I suspect genetics in humans too plays certainly a role.
I'm so sorry to bother you many times, but have you checked the growth hormone and IGF-1 level, and that may be correlated to this slow degeneration?
Well, they don't regenerate all that slow. They, like I said, they regenerate pretty well. And the Lee bioarchitecture paper showed the same thing. I was expecting to have much bigger differences than this. And they regenerate pretty well. They don't get the same size as the young and the middle age, but their baseline is smaller. They get to baseline. If you plotted their trajectory is about the same until they stop growing because they've hit their baseline size.
I think that the middle age that do start is about the same to regenerate slightly slow.
Yeah, and there are significant difference there. So and this, I remember Randy's actually been kind of my consultant on our aging papers. And so this data is in the Journal of Gerontology, and it's online, it's available, it's just not been officially published. And so that's when I officially became an aging researcher. Andy Randy made the definition. I said, so if I have something in the Journal of Gerontology, does that make me an aging researcher? So I'm officially an aging researcher. So with the adipocyte area, if we look at the males, then at baseline there's very few adipocytes within the muscle itself, right? Fat goes along the blood vessels. It goes up in between the muscle bundles, but within normal muscle there's very little fat. In a male mouse at day 7, a young one will have some fat. The middle and the old age have more fat. But by day 14, it kind of gets back down, and there's a little bit of bubbliness here. But for the most part, they're able to clear their fat from their muscle. And there's some, but not nearly as much as in the earlier stages of regeneration. Female mice, on the other hand, so I know this is low, but I'm using the same scale here that I'm going to show you with the female mice. So there's, less than 1% maybe of fat within the regenerated area. Females, on the other hand, this is not fair, but we have, as a female mice, get a lot more fat in their injured area. And the young female mice tend to be able to clear it by later time points, but the middle and old age mice still have a lot more fat that doesn't necessarily remodel away over time.
These are fat cells that are...
Yeah, remember how I showed you the pictures and you could see the fat? We don't look at the individual fat cell just because it's too hard to decide which one is, but we'll draw circles around the areas of the fat. So this is the area, the percent of our injured area that's regenerated that is now occupied by fat.
These are all acute injuries, one acute injury, the animals throughout their aging.
Right, and so each time point is a different group of mice because we have to sacrifice them to do that. So this isn't a continuous variable, it is different groups over time. So,
Trying to think about this with respect to humans and aging. When you do some exercise that causes your muscles to be sore, for example, how much injury is taking place during that? Because what I'm thinking about is if there's a significant amount of injury like Bess was talking about, and you do that this week and next week and so on and so forth, could that fit in with this in terms of multiple injuries, getting more and more fat, say, in your muscle? But does that kind of injury that occurs when you're overexerting or something lead to significant muscle degeneration?
well, Nick would be probably the better person to answer that question. I mean, he's done some studies on young and old and on humans, and actually now you're going to do more with exercise, but you do get an inflammatory cell infiltrate in humans with mild, with exercise that leads to mild muscle injury, but you don't get this, what I've showed you, this field of destruction and necrosis. In fact, I don't think you get necrosis. Maybe some apoptosis, but we're not talking apoptosis in my model. We're talking, outright necrosis. We have some papers where there's this idea that female mice regenerate better than males because of estrogen, right? And so we weren't expecting this. We were expecting the females to do better. So much to my chagrin, it didn't happen that way. And we have another paper that Matt McHale is the first author on, where we looked at oophorectomy and basically we did that, as well as looked at males where we took their gonads as well. And what we found essentially is that the female mice, if you do an oophorectomy, they don't get as much fat. And the males, if you do an orchiectomy on those, you remove their testicles, and we waited till they were 12 weeks of age so that they were mature, so we didn't do it earlier. They get more fat. And when we did some estrogen replacement and that, so it didn't really, I think you have to have that cycled hormone. It's not the same thing as giving estrogen all the time or progesterone all the time. So there are a lot of papers that say female mice, and these are usually like contraction injuries, so they're much, much milder than what we're showing here. And they say that female mice regenerate better. And these are C57BL6Js, or at least C57s. But that's not what we've found. So kind of to summarize the wild type mice, body and anterior compartment weight. In males, they have a similar body weight and a decreased anterior compartment weight in really very old mice. And the females, basically their body weight and their anterior compartment weight increases at middle age and then goes back down. Myofiber cross-sectional area is decreased and old at baseline in males and females. Males really have pretty similar regeneration once you hit that baseline size. And females have decreased regeneration, and middle age did not reach their baseline even by day 28, though I suspect if we would have taken them out longer, they would have eventually reached baseline. And then we kind of feel that cross-sectional area is probably a more sensitive indicator of sarcopenia than weight, that it's going to change first before the body, before weight does. And then adipocyte area, it's increased in females compared to males. And middle and old age females maintain their adipocytes in the injured area longer than the younger females. So what happens to MCP-1 and CCR2 knockout mice? So this is just CCR2 knockout mice, and this is the myofiber cross-sectional area, and so this is a submitted manuscript. But you know, this is the young males, the middle-aged males, and the old males. And then basically with this, we used stippling to indicate female, so young, middle, and old. And what you can see with the CCR2 knockout mice in their baseline, that essentially they do get sarcopenic, that the old age CCR2 knockout males are smaller than the young, and the same with the females. And in fact, the CCR2 knockout mice, and it's statistically significant, and we've seen it kind of over and over, their baseline fiber size is actually a little larger than the wild type mice. The wild type males are around 2,500, and a CCR2 knockout male on average is around 3,000. But they get sarcopenic. But what happens then with regeneration is you can see that really there's no difference between males and females and between young, middle, and old. I mean, there's a few that are statistically significant, but this is about as boring of data as you're going to possibly get. So they don't regenerate well. So at day 28, they're still only about 30% of baseline fiber size, but it really doesn't seem to matter whether you're a male or a female CCR2 knockout mouse, or if you're a young, middle, or old. So we wondered, do CCR2 knockout mice ever get back to baseline? We've looked at day 42 time point.
And that there were no wild types.
No, this was all CCR2 knockout mice. It gets really confusing if I put the wild type and the MCP-1 and the CCR2 all on the same graph. And I think when we did this data, we started this actually off of a Nathan Schock Center grant. But of course, with aging research, it took us years to get the mice and be able to collect enough data to get to this point. Yeah, so you know that.
That's what makes you an aging research.
I know. Yeah. By the time I retire, I'll have some data. This is great. So we looked at young male mice, and we injected them with cardiotoxin, and we waited 84 days. So it's a long time, all right? And we did the cross-sectional area different because we figured that some of the centrally located nuclei by this time would migrate to the periphery. So when we looked at the cross-sectional area of these mice, we did peripherally located versus centrally located versus combined. So you can get on a spreadsheet the cross-sectional area of every fiber, and so we just denoted whether they were central or peripheral, and then we combined the data and got an average. So for cross-sectional area, peripherally located nuclei, there are only 1,000, and baseline males are about 3,000. So and that was really about the same size that we got to at day 28. So they really don't get any bigger than what happens at about day 21 to day 28. Unless there's some growth spurt after day 84, they never get back to baseline size. The centrally located nuclei, myofibers of centrally located nuclei, were actually significantly bigger than the peripheral, but not by a lot. And then the combined cross-sectional area of peripheral and central was, about 1,200. And then we did a mean fiber count to say, okay, how many of these are peripheral, how many are central? And you can see that by the time you get to day 84, the vast majority of these were peripherally located. And I can tell you I had the best person who has ever done cardiotoxin injections do this, because I can always screen out a bad cardiotoxin injection on earlier time points, but I knew I couldn't screen it out here. And so 72% of these fibers were peripherally located by day 84. So the CCR2 knockout mice never get to baseline.
Do they, after recovery, do they retain physical activity? Are they more frail, or?
You wouldn't be able to tell the difference if you looked at them in the cage. We've never done aging studies on them, to talk about lifespan. We do have weight data on them, and actually the male mice, in the wild type, at the time points we looked at, they didn't decrease in weight, but the CCR2 males were starting to lose weight at an earlier age than the wild types. So why that is, I don't know. We always kind of thought that we're a macrophage-centric lab, and that kind of explains a lot about aging, right? If your immune system or something central becomes defective with age, then that could affect a lot of your peripheral tissues. And so inflammation, macrophages, or something from the bone marrow traveling to your tissues is a nice way of explaining that. So we always thought that our MCP-1s and our CCR2s would probably not regenerate differently with age, because we felt like they already had an impairment. So this goes back to the days of Arlen, right? Because that's when I got, yes, that long ago. That's when I got that Nathan Shock Center grant, and he told me that that was not a sexy hypothesis at all, and that they would be worse. So that's the hypothesis we went with, but they don't change. And so what about adipocytes? Well, CCR2 knockout mice have a large adipocyte area. And this is what happens with aging. The males have less adipocytes than the females, just like the wild type. But it's, look, a female mouse at day 28 can have about 16 to 18% of their area of injury replaced with adipocytes rather than muscle. And it retains. And even the males seem to have more. They don't really get rid of it like the younger males do. And it kind of follows the same trajectory, at least for the females, that the young females have more than the young males, but the middle and old age females don't seem to remodel their fat and get rid of it over time. C57BL6J.
Okay, are you comparing 28-day-old or 28-month-old mice that have been injured and recovered compared to, for example, fiber diameter as well as the fat 28-month-old non-injured animals?
Yeah, that's what the baseline data is.
Okay, all right.
Right.
Not being compared to young animals.
Yeah.
So,
Yeah, it did. Here's, let's see. So this is young, middle, old, right? Male, female.
but that's an animal that's been injured and you're measuring fiber size and you're measuring the amount of fat in it.
Uh-huh.
I'm asking how that compares to a comparable animal that hasn't been injured. Can you do a cross-section of the muscle at 28 months if you're doing that for 28 months? Are you comparing that to the muscle fiber size on an animal that's 8 months old? And seeing they're smaller. In other words, does the aging process without injury lead to smaller muscle fibers? Or fat deposition?
Yeah, not fat, but it does lead to smaller fibers. That's what these are the baseline mice that have never been injured. So if you think about it that way, if you look at this, we've got a lot going on here, right? We've got the baseline mice being compared to injured mice of the same sex and age over time, and you can also compare the effect of time and aging on fiber size. And so with regeneration, it doesn't seem to make a difference, but baseline fiber size, they definitely are smaller. So what about MCP-1s? So this is the thing that we're still kind of working on this data, and we don't have the weights and all of that done on this. But the thing that struck us the most with this is that these mice don't seem to get sarcopenic. Their cross-sectional area stays about the same. This is young, middle, and old males. And I can tell you that there's 5 to 14 here. Some of the lower numbers are out in some of these regeneration time points. We just kept adding more and more baseline mice because I just kept thinking, well, I can't believe that they aren't getting a smaller fiber size. But their fiber size in males and in females is about the same. It's certainly not like a wild type or a CCR2 knockout. So I don't know why. I don't have an explanation. I believe it. I didn't believe it when we first saw it, so I kept adding baseline mice to the numbers, thinking, well, eventually we'll get smaller. But they don't seem to get sarcopenic. And why MCP-1 knockout would protect them from getting a smaller cross-sectional area when CCR2 knockout mice get a smaller cross-sectional area, I have no idea.
So I'm just curious about whether you looked at things like full strength and things like that to see if that's making a difference functionally rather than simply.
Yeah, we didn't. I mean, we've done everything with the hind limbs, so technically, we could have done grip strength, but these mice are all dead now. But we didn't do that, and we tried a long time to try to get some type of a muscle function test, and we could never get it to be reliable and reproducible. I mean, we did it in young mice, and I couldn't even get baseline mice to be reliable and reproducible. So I don't know. And that's a big criticism that they always make of this work is, what about the function? And I'm like, if you knew how much time and money I've spent trying to do function. But I don't have a good explanation for it. If you look at...
So that it's the old male mice, that's the thing that it's surprising that they don't...
Old male and old female MCP-1 knockout mice. So here are the males, right? Young, middle, old. Here are the females, young, middle, old. Now there's a little, this is standard deviation. So there's a little bit more of a variation in the old females, and we haven't really done the stats on this data, but I'll be surprised if there's a significant difference between baseline fiber size in our age groups in the MCP-1 knockout mice.
Did you go back to the CC?
Yeah, so the CCR2 knockout mice, the old ones are about 22 maybe. And remember, they started at 3,000, so they start bigger than the wild type. A wild type male is about 2,500 when it's young, and it gets down to about 2,100. So it's a pretty big jump. So I have nothing here to explain.
Well, it could be because there are two different things. One is the muscle wasting of aging, which is their baseline measurements, and the second is regenerative capacity. And so one argument or one interpretation would be that MCP-1 is required for sarcopenia
Are you guys aware of any other kind of knockout mice or any other mice types that, well, of course, like I said, I think cross-sectional area is a more sensitive indicator. So, you know, even in our wild-type male mice, the weight didn't go with sarcopenia necessarily, but cross-sectional area changed first. That are there other kind of knockout mice that don't get sarcopenic?
I think there are. I need to check.
I mean, I don't know why these.
Thought the model we had with NF7 would be protected, but they're not.
The inflammation's good.
Oh, yeah.
Yeah, I don't know why. And if you look at the regeneration, you know, day 7, they all look the same. Day 14, maybe the older lagging, and maybe the older lagging here. So maybe they didn't quite regenerate as well. I suspect over time, you know, they'll get back to baseline eventually, where the CCR2s are not going to get back to baseline. So I don't have much of an explanation.
Supposedly the PPC1, oh, but that was PPC1 suppressed mice were protected, but I think that data is going to change.
Now, I'm pretty convinced that the MCP-1s, their cross-sectional area doesn't go down. Like I said, I think this is, with the baseline mice, I think there's at least 10 for each time point. I mean, because I just thought, well, maybe we picked the wrong mice. How could this be? I didn't believe it either. And then when the females did the same thing as the males, I also didn't believe that the CCRTs were a little bigger. And we kept adding mice, but they are. So adipocyte area, they're intermediate, just like anything else. They have fat, but not as much as the CCR2s, and they have more than the wild type. So just to kind of summarize for sex and aging in the MCP-1 knockout and CCR2 knockout mice, the CCR2 knockout mice, the old age mice of both sexes exhibit sarcopenia. They have a smaller set point for myofiber size after injury, and they likely will never get to baseline fiber size. Regeneration is similar in males and females have increased fat compared to males. For the MCP-1 knockout mice, I think the most interesting thing about them is that they do not appear to get sarcopenic with old age, as measured by cross-sectional area, and that females have increased fat compared to males. So with the CCR2 knockout mice, what we said is if they're only missing macrophages, why don't we give them back their macrophages? Give them a wild-type macrophage. So we know they have severe impairments, and we have wild-type GFP mice. So what we did is we isolated monocytes from a wild-type bone marrow, and we did IM or IV injection of these monocytes into CCR2 knockout mice, and thought, well, if we can get them to regenerate, you know, if we can give them their macrophages, they'll regenerate. So this is an IM injection of the GFP positive bone marrow cells, and we tended to give them at day 2 just because that's when the macrophages show up. But the problem then that we found is that if we sacrificed the mouse the day after we did the GFP positive macrophage injection, we didn't have any GFP positive cells, so they died. And at day, so you can see that there, at least there's some here, and so this is GFP positive bone marrow, so about 5 to 10% of bone marrow cells are monocytes. So this was our control. We'll just give you bone marrow cells, and there are going to be some monocytes in there, but it's going to be a mixed bag of a lot of different things. And so when we did that, you can still see that when we harvest the muscle, there's not a lot of inflammatory cells, and this is the same muscle here, but you can see some nuclei, but this is all dead. In the mice that we did inject the monocytes with, you did see very small regenerated myofibers, but like I said, they didn't stick around, right? They died. And we said, fine, we'll give them to them from a tail vein injection. And of course, these are GFP positive wild type monocytes. They have CCR2, and CCR2 knockout mice make huge amounts of MCP-1. So the signal for the monocyte to migrate to the injured muscle should be there. And essentially what happened is we found really no GFP positive cells in the injured muscle, but we found them in the splenic red pulp. I mean, look at all these GFP positive cells. So that leads us to, I think, the most significant question in science. How are children similar to monocytes and macrophages? Well, they don't always go where you want them to go, and they don't always do what you want them to do. And this is really when we started becoming interested in macrophages and the different types of macrophages, because we can't, you know, we've done this with cultured cells too. We've grown macrophages, you know, bone marrow derived macrophages, and polarized them to different things and done IM and IV injections, and they just don't live. And they don't do what we want them to do, and they don't survive. Either I don't get them there with the IV injection, or if I do an IM injection, they die. So I've never really been able to test this, and there's all this data about being able to inject stuff and it improves it. But I don't know how they do it. I really don't. But if we think about the different types of macrophages, and this has been primarily worked out through tissue culture, they talk about the M1 or the classical macrophage. If you do an LPS stimulation, you get the pro-inflammatory macrophage. And M2A is the alternative, the 2s are the alternatively activated macrophages. A is if you do IL-4. There's this M2B, which is complement, and they're kind of this mixed bag where they have some pro-inflammatory and some anti-inflammatory characteristics. And then M2Cs are supposed to be the regulatory macrophage. They're the ones that dampen down inflammation and make you have resolution of your inflammation. And in culture, they're typically created by culturing with IL-10. Well, so this is Paul. He's one of my twin sons, and he's my pro-inflammatory twin, because he always creates havoc and, you know, just trying to tease his siblings, and, you know, always likes to have get a rise. This is Patrick, his twin brother, and he is my alternatively activated tissue building peacemaker twin. And then, of course, nothing would be the same without my daughter, Anya, who's my regulatory child, who, you know, if the boys would only listen to her, the life in our house would be so much easier. So children are like macrophages. So we've answered that very important scientific question, I think, beyond any shadow of a doubt. So we can stop at any time, because this is really getting more into the microRNA, and I can't see, is it really about time? I know I wanted to put all the sarcopenia and the aging data in because I knew this audience would like that. We have a lot of data on microRNAs, and to get to Yuji's question, we have some microRNAs that actually decrease IGF-1 production in macrophages. We haven't really taken that anywhere. You know, the data I have that we were going to show you is with a MER125A5P, and it basically secretes soluble VEGF-R1, which acts as a decoy and drops the VEGF in the media. So we have some microRNAs that definitely change what the macrophage does, and with the hope that, you know, could we get either a cocktail of microRNAs or to be able to improve muscle regeneration. So it's almost 5, right? So why don't we just, if there's a few questions.
If you are going to sport here, can you show just the summary of the discussion?
Summary of the.
Yeah,
You want to go forward a few slides.
Let's see. We all know David. So this is David's paper that's in press, and this just shows the culture conditions. And we basically wanted to make sure the culture conditions that we had created either pro or anti-inflammatory. So these are media-only macrophages, which have not had any stimulation. These are the LPS stimulated macrophages. These are the IL-4 and these are IL-10. And so we've measured both the cytokines in the cell and in the culture media, because what we were looking for is what's happening in the cell. So if a microRNA increases or decreases something, the media could lag behind long after. So, all this shows essentially is that IP-10, which is a pro-inflammatory cytokine, as is MIP-1 beta, it definitely increases in the pro-inflammatory macrophages, but not so much in the others. So this is the VEGF data, and this is in a paper that David is the first author on that shows VEGF-A. And what you can see is there's quite a bit of VEGF in the media itself. And so this is the media itself, and then these are the media-only macrophages that aren't stimulated with anything. With LPS, we get a little bit of increase in VEGF. And and this is just cellular. In the culture media, on the other hand, this is the media, and this is where the VEGF is. So there's VEGF in our media, and it stays pretty constant. It goes up a little bit in the inflammatory, but it really severely decreases in our IL-4 treated macrophages. And we also didn't believe this initially. And we looked at a bunch of stuff, and we kind of figured that, like I said, the upshot of it is that that basically VEGFR1 is an RNA that with alternate splicing either becomes membrane bound or will be soluble in the media, and it's thought that the VEGF binds to the decoy VEGFR1, the soluble, and sequesters it so that VEGF is not available to be used. And we do see an increase in VEGFR1 in our cells with IL-4 treatment. Now, we don't know if this is membrane, if this eventually becomes membrane bound or soluble. But it does become, this is just us showing that we can actually either mimic or inhibit the 125A5P. And this is our media only with soluble VEGFR1. And if you put in an inhibitor to 125A5P, the soluble VEGFR1 goes up in the media. And so what this is this is our media. This is our control. This is media from our control macrophages that didn't have any transfection at all. This is a scramble mimic. This is the 125A5P mimic. And this is the inhibitor for 125, the scramble and the actual inhibitor itself. So when the soluble VEGFR1 goes up, the VEGF in the media goes down. We've never done kind of immunoprecipitation experiments to see if you could actually pull those out. Now, I don't have the IGF-1 data on this, and like I said, it's kind of getting late. There's a lot of microRNA data that we have with our macrophages. We've even been able to mimic MER9, which is, we think, a pro-inflammatory MER. And when we elevate MER9 in our skeletal muscle, we get more pro-inflammatory cytokines in the muscle, which, of course, that's not particularly good for muscle regeneration, but let's see. Is there any other questions? Oh, I probably at least need to get to this part. Oops, the acknowledgements. Obviously a lot of people do that, and then, she turns 13 next week, so this is very much a typical Anya picture.